who you're going to start. Terrific. Nice to see you again.
Nice to see you again. Thank you. My name is Katie Murphy. I serve on the M&A Board of Directors, and I brought my lunch. I'm used to doing my work through lunch. Thank you for taking this testimony on the proposed regulations for the ICU nurse staffing. I testified previously that I have 4 decades of nursing experience, 38 years of them in critical care. I point out to my newer colleagues that when I began nursing, there was digoxin, lidocaine, and a defibrillator. People died of acute kidney injury. We didn't see any adults with secondary malignancy due to the therapy they had received for their childhood leukemia. Most of them died. Today, we routinely dialyze the most fragile patients, pull them through their acute crisis, and send them back to the medical floor where many are discharged. We support young parents on extracorporeal membrane oxygenation until lungs become available for transplant. We save life and limb, and then, when we cannot, we sit for hours at a bedside and help our patients to a peaceful death. The stable patients are at home. When my patient has survived a critical illness and is ready to be transferred, I'm able to take a second patient. It only makes sense. I work the night shift. There's a finite number of critical care nurses to be found at 2 a.m. We make sure that the patients who need the most intensive care receive it, but only the professional providing that care can make that determination. I work at 2 hospitals, a big Boston teaching hospital and a for-profit community hospital. At the latter the other night, there was a patient who was intubated, on a ventilator, on vasoactive infusions, and receiving many medications as well as enteral feedings. She had many draining wounds requiring frequent position, dressing, and linen changes. This required 2 persons, and since this community hospital provides no ancillary personnel or secretary after 3 p.m., this means 2 nurses. The supervisor arrived in the ICU, didn't assess the patient, go in and look at the patient, or assist with care of the patient. She announced that the patient was not a one-to-one. This is the very essence of our goal to protect our patients. Should this patient survive and thrive, the nurse providing direct care would be able to determine whether there was another patient on the ICU who could also receive excellent care if this nurse were to be responsible for both of them. The professional judgment of the nurse must be the determining factor. Any acuity tool is just that, an instrument to support the nurse's assessment as needed. I use Quadramed at the teaching hospital. I dutifully check the boxes, but do not believe it captures the intensity or the reality of the critical care bedside. It's similar to you reporting to a friend that you sat in hearings all day. Gee, doesn't sound too tough. Only you are aware and understand that you hold people's lives in your hands. Thank you.
Thank you, Katie.